Hey everyone, in this video we're going to talk about the cardiovascular effects of PEEP. And this is a topic that comes up in anesthetics and ICU and cardiology because something you can do as a doctor, say in an emergency scenario or on the wards, is give someone CPAP for a failing left ventricle. And CPAP doesn't work the way a lot of people think, in that people say during pulmonary edema you give CPAP, which is giving PEEP. And some people believe that it somehow pushes fluid into the alveoli back into the circulation. But that's not how it works. From an oxygenation point of view, it opens up more collapsed alveoli. So you have better FRC, better lung compliance. But from a cardiovascular point of view, it can also act as an inotrope and help the left ventricle in contraction. I'm going to explain this further as we go through this video. So you can see in front of you, there's two images and they're the same. And in black, this represents the chest wall, which is sort of essentially a fixed box, though it is flexible. But in this scenario, we're going to just make it fixed. In blue, we've got lungs, and this is just the circle that sits within the chest wall. And then in red, we've got the heart, which sits in amongst the lungs, right? And then from left to right, you have blood that enters, which is the inferior vena cava, superior vena cava, and has to come in through the chest wall, travel up through the lungs to then get to the right ventricle marked by R. It then has to exit out into the lungs and then enter the left ventricle, and then it exits out through the aorta and eventually will also exit out from the chest wall, right? So on the left, we've got no PEEP, and on the right, we'll talk about a scenario with PEEP. So the left ventricle has to push against 80 millimeters of mercury to open the aortic valve, because this is diastolic pressure. So during diastole, this is the blood pressure that's in the arterial system. And we know that because this is the minimum, for the left ventricle to open the aortic valve, it has to generate over 80 millimeters of mercury of pressure. But it gets more complex than this, because within the chest wall, there's negative pressure. And this is the intrapleural pressure, and it's about negative 5 millimeters of mercury in this scenario, which is pulling the lungs out to keep them expanded. So you've got the heart trying to collapse inwards to eject blood, or contract inwards, and you've got the chest wall pulling out to try and expand the lungs. So you've got these two pressure systems that are acting against each other. And what this does is that it translates to the transmural pressure of the left ventricle. So if we were to put this into an equation, it would be whatever's in the left ventricle minus whatever's outside the ventricle for pressures. And because it's a negative pressure, it becomes 80 minus negative 5. And because it's two negatives, it becomes positive. So realistically, it's 80 plus 5. So the left ventricle is actually needing to overcome that 5 millimeters of mercury of negative pressure to be able to contract inwards and eject blood. Now for the right side of the heart, it's doing the same thing. It's actually pulling the vessels outwards, so the inferior vena cava, the superior vena cava. So when you take a breath in, that extra negative pressure is actually sucking blood in and then increasing the preload within the right ventricle. So it improves preload of the right ventricle. Now let's take the scenario on the right with PEEP. Now, same thing, you have a blood pressure 120 over 80. You have your negative 5 millimeters of mercury in intrapleural space, and the left ventricle needs to overcome that 80 millimeters of mercury. But let's add in PEEP now of 10 millimeters of mercury. And remember, this is a hypothetical scenario where usually when you use PEEP, it's in centimeters of water, but I've just changed it to millimeters of mercury to make it easier to understand and fit with the maths. So the PEEP is now within the lungs and it's pushing outwards. So it's pushing out against that negative 5 millimeters of mercury, and it's also pushing inwards against the left ventricle. So again, remember, we've got to do whatever's in the left ventricle, the pressure, minus whatever's outside. So it becomes 80 minus 10, which is 70, minus 5. So because it's minus the negative number, it becomes positive, which is 75 millimeters of mercury now, because it's 80 minus 10, which is 70 plus 5, 75 millimeters of mercury. So realistically, the PEEP scenario versus the no added PEEP scenario, you actually have an improvement in the transmural pressure gradient of 10 millimeters of mercury. So the heart's pumping in the no PEEP scenario against 85 millimeters of mercury, while in the with PEEP scenario, it's only pumping against 75 millimeters of mercury. So the LV has a decreased workload. Now, when we look at the right heart, again, the opposite happens compared to the no PEEP scenario, where before the negative pressure was pulling the inferior vena cava and the superior vena cava outwards, sucking blood in. Now the PEEP's collapsing it and pushing inwards. And you can run into a scenario where once your PEEP is greater than your preload pressures for the RV, so usually the right atrial pressure is around 5 millimeters of mercury. Once it's greater than that, you can run into scenarios where you collapse off your preload and reduce the RV filling. But that will be something we can talk about in another video. Now, we mentioned before how blood has to exit the right ventricle to enter the left ventricle, and this is through the pulmonary circulation, so through the pulmonary artery and the pulmonary veins that then drain back into the left ventricle. And they're not immune to the changes that happen with PEEP as well. So when PEEP is applied, the PEEP also compresses these vessels, which reduces preload to the left ventricle. And this is important because the reduced preload to the left ventricle means that you have reduced filling. And if you have a large failing left ventricle, it wants less filling so that it can then contract more. So, because remember, it's overstretched if you think about your Frank-Starling law of the heart. So to summarize what PEEP does, for the right ventricle, it reduces preload and it increases afterload through compression of the pulmonary arteries and veins and the pulmonary circulation. And for the left ventricle, it decreases preload, decreases afterload, and decreases LV transmural pressure, which in essence reduces the work of the left ventricle. So in a sense, it helps as an inotrope. And it's a pretty basic thing that you can do to help these patients who are in pulmonary edema with a failing left ventricle. But then when it comes to right ventricular failure, you need to think a bit harder about it, because if you were to add PEEP, you can make it worse. Thanks for watching, and if you guys have any questions or anything you want to ask me in the comments, feel free. And remember to follow me, because I'm going to release more physiology content and we'll apply it all as best we can to the real world.